Kia ora koutou, and thank you for joining us this evening for Heart Failure Therapy from Past to Present. My name is Andrea Copeland and I'm the Custom Education Lead for He Ako Heringa, and we're very pleased to bring you this webinar tonight. I'd first like to introduce Dr Raewyn Fisher, who will be presenting the webinar, then we'll quickly go over some housekeeping. Dr Fisher is the Clinical Lead for Northland DHB Cardiology and the current Chair of the New Zealand Cardiac Society Heart Failure Working Group. She's been a member of the Cardiac Society of Australia New Zealand Regional Committee for many years, having had input into local heart failure care pathways. Dr Fisher is passionate about developing equitable care for all heart failure patients, and we're grateful to have her presenting this evening. So without further ado, I'll hand over to Dr Fisher.
Good evening. Thanks for that introduction, Andrea, and welcome everyone for giving up some time this evening to take part in this webinar. So I'll kick on and I'll share my screen. Hopefully that's all working okay for you. So as Andrea was saying, this is an update in heart failure therapy, and it is actually quite useful and also quite entertaining to find out where we've come from in terms of heart failure treatment. I'm going to go over things in very general terms, and most of what I'm talking about is based on lots of evidence-based research, but it's really how I'm putting it into practice as a clinician specialising in heart failure. You don't really have to be a specialist in heart failure to manage heart failure patients. We've all got them in our practices and in our communities. So we're all pretty familiar with what heart failure is. It comes in various forms, hopefully not quite as gross as the old dropsy. But it is important that we're actually conscious of how we talk about heart failure, because it is a very negative term. And so when we talk about heart failure, the patients often sort of get a very gloomy outlook that, the end of life is nigh. But in fact, what we actually mean when we're talking about heart failure is that the heart's not doing its job right at this point. So it's failing to do its job properly. It's not the end of the road. And certainly with new heart failure treatments, it isn't the end of the road. Now, one of the important definitions to be aware of is the role of the ejection fraction, so the pumping function of the heart. And in broad terms, there's heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. And most of what I'm going to be talking about today, and most of the therapies, are directed towards people that have got reduced ejection fraction or weak pumps. There's massive evidence from clinical trials. I'll just say a brief comment about the HFpEF, or heart failure with normal or preserved ejection fraction. It is quite common. It may present in a similar way in terms of breathlessness and fluid overload, but treatment is not quite as clear, and studies are ongoing. So for the purposes of the rest of this talk, we will be talking about HFrEF. We're actually uncertain of the real world incidence, because we can measure what comes into hospital, where it's clear that there is a diagnosis made. But in fact, the diagnosis is not exactly that easy early on in illness. And so we don't actually have a real estimate, but all we do know is that it's increasing worldwide. And part of that's got to do with the ageing population. We're saving people from their heart attacks, their cancers, and so heart failure is becoming more common. And also, it's not just the older people with weak hearts from ischemic heart disease. There's a lot of newer heart failures, people that have had heart dysfunction as a result of cancer chemotherapy. And also there's a lot of disparities that relate to ethnicity and deprivation, and that becomes incredibly important, particularly in rural New Zealand. So, a rough estimate is that one in 5 of us will develop heart failure in our life, and heart failure mortality is still pretty high. And more importantly, from a resource point of view, heart failure hospitalisations are really high. And they're particularly high in our Maori and Pacific population, who have twice the mortality rate and 4 times the hospitalisation rate. And what's more, if we look at Maoris in their 50s, their hospitalisation rate is 7 times more than the New Zealand European population. And that's work that I've measured from Midland across, Waikato region, as well as in Northland here. So it's a huge health burden, and that's where we should be putting our money, if we're going to focus at prevention and reducing health burden. I said it, long-term survival is poor. About 20% of people are dead by 1 year, so 1 in 5. This is after a hospitalisation. Half of those patients are dead by 5 years, and about 70% by 10 years. So if you compare that with a lot of cancers, the long-term survival is poor. However, that is improving. And so this is, as we've sort of gone across with different studies, is that, very first, our vasodilators, our ACE inhibitors, beta blockers, mineralocorticoid antagonists, Entresto, our diabetes drugs. So as time has gone, this is essentially a timeline of mortality. The mortality from heart failure diagnoses is gradually improving. So yes, it was dismal, but it's getting a lot better, and it continues to get better if we use these agents appropriately in our heart failure armamentarium. And more importantly, getting back to the sort of burden on our health system, is that, readmissions are in fact very costly. There's a high readmission rate after you've been discharged from heart failure, and I want to sort of focus a little bit on how we can address that to prevent those early readmissions. If we look at an individual patient heart failure journey, this is a timeline, and it can be weeks, it can be years. There is a long period of time without symptoms. So you might have cardiac dysfunction, a reduced ejection fraction, and you can either suddenly develop symptoms or more gradually over a period of sort of weeks to months. And so this is often the time that people are first diagnosed with heart failure in GP land or in hospitals. And what we tend to do, some of them will not survive that first episode, but the majority of them will in fact improve and will have a fairly long period of stability with these sort of exacerbations or decompensations, as we call them, that may result in hospital admission. And so what we're aiming at doing really is to increase the time that the patients are alive, but also reducing these decompensations. So I was talking about the readmissions. One of the common errors that I think happens at during the hospital admission and at hospital discharge is not understanding why the patient has ended up in hospital in the first place. And so if we talk about that patient having those dips, for example, it may be because the patient hasn't taken the medication, they haven't been able to pick it up, they can't afford it. It may be because they've drunk too much. There's various reasons. They may have developed atrial fibrillation. So I think it's important that we understand as clinicians why the patient ended up in hospital to prevent that happening again. Often there is this pressure in hospital beds to get people out quickly. And so often people are still sent out of hospital where they're a little bit wet. Okay, so we really want to get the patient at their dry weight and have them on an appropriate diuretic dose at discharge. This is something that can't be emphasised enough, is that it is really important that the patient, the whānau, have an understanding of their condition, how they manage it themselves, preventing too much fluid intake, preventing too much salt intake, picking up on those warning signs of early decompensation. And the thing that we can do sort of as a heart failure team is aiming for optimal medical therapy. And what we want to do is to get them on that sort of cocktail of drugs that are helping people, get better, live longer and better quality of life, get them on those treatments early and up titrate them, usually within the first 3 to 6 months, because if we don't grab that opportunity of that 50-year-old Maori man that's decompensated and gone home, if we don't get stuck in then and improve things, he's set for a longer period of morbidity and mortality. And as part of this strategy is that early review and clinical monitoring. So just a few definitions. I mentioned there optimal medical therapy. You may see it described as guideline-directed medical therapy. Essentially, what that means is we're aiming to get the patients on the target dose or the highest tolerated dose for that person. And that's what I want to sort of spend some time talking about in terms of current therapies that are available in New Zealand. This is actually quite a good read that's up to date. It's, from the American medical system, but it's very, very recent, and I'll point you towards that for a good read. What it does is it essentially talks about putting optimal medical therapy under 3 categories. It's how to implement guideline-directed medical therapy, which is what I'm going to talk about, that's starting people on medication and titrating. But it does also talk a lot about these practical things like challenges of getting people to take their medication and systems that we can develop around them, as well as those more complex patients with other conditions and end-stage disease. So for the purposes of this talk, which is sort of more medication orientated, I'm going to come back to this, how do we implement this optimal medical therapy? It's really important to keep things simple. I can't remember more than 5 things on a slide most of the time. So if we talk about heart failure therapy, it's basically diuretics, ACEs, ARBs, beta blockers, your MRAs, which are your essentially spironolactone, and your ARNIs. Okay, so there's 5 categories of drugs that we should be thinking about. Now, diuretics, there isn't actually a lot of evidence that diuretics work. We all know they work, but it's not actually something that's been trialled in a randomised trial because it's unethical not to give diuretics to wet people. And we know even in the very early days that getting rid of fluid in various ways was important. Fortunately, we've moved on a little bit, and again, sort of the 5 take-home messages about diuretics. If people are wet, if they've got edema or lung congestion, they need diuretics. Even if their blood pressure's low, and a lot of our heart failure patients wander around literally with blood pressures of 90 or so, if they're otherwise stable and they're wet, they still need their diuretics. Diuretics is usually frusemide. Thiazides are useful in combination treatment. And one of the reasons that people decompensate with heart failure is that their oral treatment's not working. So they get some fluid build up, their gut gets congested, they don't take and their frusemide tablet isn't absorbed. And so they'll come in and say, my tablet stopped working. Okay, and that's the situation where the dose needs to be increased, or they need to be given intravenous diuretic. And again, that aim is we're trying to get these people dry. Otherwise, things just don't function so well. Okay, your ACEs and your ARBs, and I lump those together for several reasons. Both of them are useful, in fact, more than useful, have proven for people with heart failure with reduced ejection fraction, whether they've got symptoms or not. Okay, I'll come back to the difference between your ACE inhibitors and your angiotensin receptor blockers. Essentially, all of these agents have a similar benefit in reducing death, heart failure, and hospitalisation. I could show you 101 different studies to prove that, but that's why it's accepted as part of standard treatment. And again, it's titrate to that maximum tolerated dose. You do, of course, with these medications, need to monitor their renal function with dose changes and may need to adjust the diuretics depending on their volume status. So if we come to the practical use, and I was talking about, up titrating to the target or maximum tolerated dose. These target doses here for your prils or your sartans are those that are shown to have the most benefit in clinical trials. Okay, so for example, 50 milligrams of losartan is good, 150 is better. So we're really aiming at that target dose or the maximum that the patient will tolerate. Okay, and it is important, treat the patient, not the blood pressure. You don't want to treat until their blood pressure is 120, like with hypertension. You really want to increase the dose as much as the patient will tolerate without falling over. Okay, and again, that monitoring, that particularly early after hospital discharge or decompensation is really, really important. If we're talking about ACE inhibitors, again, which one is better? Are they all the same? There's various studies. If you look at mortality, stroke volume, ejection fraction, all these things, you'll find that some are better than the other. You know, look, at the end of the day, one may be slightly better in some study. They're essentially the same. So whether you're talking about quinapril, cilazapril, or perindopril, they essentially all have the same sort of benefit in terms of heart failure and various sort of physiologic parameters that go with that. So, you know, a prill is a prill is a prill, which becomes really important because cilazapril has been widely used in New Zealand for a long period of time. It's a great drug. You know, I've loved it, and the fact that it's going out of production, it's a bit of a shame because we've been familiar with it. But having said that, it's not a disaster, because if we actually look at the benefit of cilazapril and the tolerability, it's really pretty much the same as all the other prills. Okay, so this here is from the New Zealand availability. So these are all the subsidised ACE inhibitors, okay, and the doses that are available. So we've got plenty of choice to swap our cilazapril patients to. And again, it's like anything, if you're changing from one drug to the other, the patient may be a little bit, you know, uncomfortable. But in fact, the thing is, they're all the same as long as you're looking at the equivalent dose. Okay, and again, we're looking at getting the most bang for the bucks. So again, getting the patients on board with changing the ACE inhibitor, make sure that you're actually changing to an equivalent dose, or even better still, if it's from heart failure point of view, use that opportunity to sort of think, actually, I could get them on a bigger dose and then get greater benefit. Okay, so again, use that opportunity with all your cilazapril heart failure patients. Don't stop it, just change it to something and use that opportunity to up-titrate. What about your ARBs? If you look at various studies, it's pretty much the same. Okay, so you could, you know, change an ACE inhibitor to an ARB. Okay, essentially from the mortality, morbidity, pretty much the same. And also they're often better tolerated, as you well know, because of less cough. Okay, let's get back to that table about sort of what do we change to. I mean, we need to be sort of conscious about funding. Now, this is some maths I did out of the you know, current pharmaceutical schedule. So if we're looking at, you know, maximum or target doses, these here are the costs per 90 tablets. Cilazapril, enalapril. Bear in mind that that's usually as a BD dose of 10 milligrams, so that we're looking at that cost. Lisinopril, perindopril, okay, if we look at 4 milligrams, but in fact, the target dose for that is 8 milligrams. Okay, so I know there's a lot of perindopril being used, and it's a lot of it is what prescribers are familiar with. Okay, I mean, we all tend to do that, but it's actually quite a costly alternative. These figures will obviously change, and quinapril, because it really should be for heart failure 10 milligrams BD, we're looking at, you know, those dollars. So, you know, there is a cost difference here with, you know, the obviously cheaper ones being enalapril and lisinopril, enalapril BD. So what about your sartans? It's always been, you know, taught that we should use an ACE inhibitor first before an ARB, and historically that's been because of a cost issue. I mean, these fellows here used to be very expensive, and so you know, those of us that have been around for a while, we actually had to have people try them on 2 ACE inhibitors before you change them, you know, applied for funding for a sartan. Things are quite different now, and if you look at the cost, these are a lot cheaper. So I think the recommendation of using an ACE before an ARB isn't really cut and dry or mandatory. And I'm happy to discuss that, you know, where it may be appropriate to choose one or the other in the discussions. Okay. All right. So what about, I mean, what sort of cocktail? So that's part of the cocktail. We've got them on the ACEs and the ARBs, and we know that, there's various sorts of cocktails should be used, even sort of going back in the 1900s. The next part of the cocktail is the beta blockers, and you'll see a continuing trend coming along here. This is for everybody with heart failure with reduced ejection fraction, regardless of symptoms. There's 3 beta blockers, all proven in heart failure. Similar benefit, okay, but varying tolerability. And we'll all know that the metoprolol sort of tends to make people feel a bit sluggish, particularly at the higher doses, whereas that's less of a problem with the carvedilol and bisoprolol. Carvedilol needs to be given twice a day, which, may reduce compliance. Okay, but it doesn't matter which beta blocker that the patient's on, that you start them on. Again, it's up titrate to the maximum tolerated dose for that person. Okay, and bear in mind that the beta blockers have got other benefits if you've got angina, if you've got ventricular arrhythmias, and in fact, it's a preferred agent for AF rate control rather than your calcium antagonist or digoxin. So there's lots of reasons, why beta blockers are useful in this population. All right, same sort of thing. We're treating the patient and not the blood pressure. We're aiming at getting their heart rate around 60 in sinus rhythm, about 80 in atrial fibrillation. So that's where we're aiming at. These target doses are the ones proven in the studies. Again, big doses of metoprolol. Okay, again, that's where you start to get side effects. Bisoprolol, newer to New Zealand, and carvedilol with bigger dose, which we often forget about in older people. Again, I was sort of quite surprised the difference in this. This is again from the August schedule, 90 days, big difference in cost there. Okay, and again, these will change. Personally, I'm starting bisoprolol for most people, not because of the cost, but because it tends to be better tolerated in terms of there's less fatiguing effects, there's less respiratory, minimal respiratory risk, less nightmares, erectile dysfunction. So there's a variety of reasons that a lot of us are actually moving away from metoprolol as first line. Again, the dose does matter. I'll just touch on this briefly. I mentioned it before, is that you get the biggest benefit if you get to the maximum dose. Okay, but there is this continuum. So some is better than none, but if we can get them to the biggest dose, the better. Okay, and the other thing is that I think it's really important when we're talking to patients with heart failure, they say, how long do I need to be on this? And even if you get people up to normal ejection fraction, there's a lot of evidence that if you stop the treatment, things will deteriorate. So again, people have to be understanding that it's a lifelong therapy. Okay, there's real risks of decompensation and subsequent deterioration if you stop treatment. And again, that's another reason to be thinking in this, cilazapril situation, it's a timely thing to review. Don't stop it. Use the opportunity to look at the whole heart failure cocktail. Okay, and again, the whole sort of, heart failure cocktails, again, this is, very historic stuff. The old heart failure physicians, knew that there was all sorts of, combinations worked. So our most recent combination is urani, which is your ARB, so it's valsartan, plus a neprilysin inhibitor. And what we're doing here, of course, we're not adding. What we're doing is we're switching your ACE or ARB if they've got symptomatic heart failure and poor ejection fraction. And again, getting patients on board, that switching rather than adding another tablet becomes important in terms of compliance. Essentially, this is very complicated for this time of night, so I apologise for it, but essentially the valsartan over on the right here, so that blocks your renin-angiotensin system, so it works like all your ARBs, but this drug, the sacubitril, which is the neprilysin inhibitor, potentiates all the vasodilating and good stuff. Okay. All right, and what we know is we talked about your ACEs and ARBs reducing your mortality. Your ARNI almost doubles that mortality benefit, okay, as well as reducing hospitalisation, improving quality of life, etc. So if we go back to the international guidelines, so again, this is from the original document that I started, they're actually moving, so this is symptomatic heart failure, right up the top here, they are actually saying first treatment is ACE, ARB, or ARNI, and in fact the ARNI is preferred. In New Zealand, things are a little bit different, and I'll talk about how we can prescribe it, but I think, you know, we are going to be hopefully seeing more use of ARNIs, you know, as first-line treatment in appropriate people, always with the beta blocker and diuretic agent as needed. So that's, you know, creating your cocktail. Similar sort of thing in the European guidelines, you know, they're actually suggesting that initiation of your ARNIs rather than an ACE inhibitor may be considered for patients with new onset or decompensated. So, you know, again, I think we're going to see that move. Certainly overseas, there has been that move, but we need to be cost conscious and certainly play by the rules. The rules in New Zealand, special authority, you've got to have heart failure with reduced ejection fraction with an EF less than 35%, symptomatic heart failure, and already on optimal medical therapy. Okay, so again, that's quite a lot of our heart failure patients. You don't have to get an echo if it's not practical, and this is a clause that came out last year when echoes were not that, were even less available than they are normally because of COVID. So, but I think it's important that you've, you know, made an effort to get them on, you know, standard optimal medical therapy before you think about Entresto. There's 3 doses of this, and again, like your other agents, we're aiming at this target dose. So we may start low dose, we may start middle dose, depending on what we're switching from. And I think that's the important thing. You know, we're not actually adding another tablet, which is important from the patient's point of view, but we've actually combined the valsartan with the sacubitril, normally starting at this middle dose, but may look at a lower dose for older people, people with low blood pressure, but again, always aiming towards the higher. So, you know, you're seeing that there's a similar theme with all sort of heart failure medications. How do we switch it? If you're going from an ARB to an ARNI, you basically just stop one and then start the Entresto the next day. And that's a reason that some of us are actually starting patients with very low ejection fractions on a sartan rather than a pril right off, because we know that we're going to end up getting them on Entresto, so it makes that transition so much easier. If you're going from a pril to Entresto, you do need this sort of washout period because there's a risk of angioedema. Again, from a practical point of view, what I do is I say, take your last pril on Friday, start the Entresto on Monday. Okay. Similar sort of monitoring, and a lot of these people can reduce their diuretic. I mean, it is really a step up to business class for these people. You know, they often come back, you know, when we see them in 2 to 4 weeks, and they feel so much better. Okay, just a brief note on your MRAs. Okay, so this is essentially spironolactone, and most of the trials have been done at a dose of 25 milligrams. It is a fairly weak diuretic, but it's actually a reasonably good antihypertensive. So you need to be a little bit careful in people that have got high potassium or low blood pressure. There's good evidence that it reduces, you know, improves the function and structure of the heart. Need to be a little bit more careful with this, again, potassium and renal impairment. So it just requires a little bit more monitoring. One of the not uncommon side effects is gynecomastia, which, you know, males particularly don't tend to like, you know, a bit of breast development or breast tenderness. But in fact, under special authority, you can swap spironolactone for eplerenone. Essentially, it's spironolactone without the boobs. Everything else, all these precautions are pretty much the same. So if we're looking at people getting on that full cocktail, you know, we really should be thinking about this as well. Okay, so that's sort of most of our armamentarium in terms of heart failure medication. Okay, although times are changing. Most of you will be aware of the move towards the new diabetes drugs, your SGLT2 inhibitors. This is a heart failure talk, and we're in New Zealand, so I will just sort of mention this because I think it's somewhere that we're going to have to go. These medications, whether you're diabetic or not, do have evidence of reducing heart failure, new diagnosis, and rehospitalisation, death, etc. So internationally, they've actually put these SGLT2 inhibitors as, you know, part of the heart failure guideline. Okay. So, you know, your diet is sitting down here with your spironolactone and your diuretics. So I think we should be thinking about, in New Zealand, our diabetic patients that have got heart failure, you know, that's an ideal group. It's not they're not currently marketed or, sorry, approved for use in heart failure. But again, if you're looking at diabetes management in somebody with concurrent heart failure, it's, you know, more than logical. Okay, the other thing that you do need to be aware of with these agents, which is a good thing in our heart failure patients, is that they tend to get rid of your glucose. So a lot of people that start the SGLT2 inhibitors have quite a marked diuresis, and there may be a transient increase in creatinine. But of course, that's an advantage for most of our heart failure patients if they have a bit of diuresis. But you may just need to, you know, reduce their frusemide a bit. So it needs to be a little bit cautious, and I'm sure you'll have received education about the use of these in diabetes. It would be remiss of me not to mention the sort of non-pharmacologic and, you know, other challenges that we've got. I mean, we'd like to be able to just prescribe these cocktails to all our heart failure patients, but just telling people and getting them, you know, to take their medications, it's not that easy. And again, the American document here that's referenced here, there's challenges with referral. You know, do you need to be seen by a heart failure team already? You know, are you comfortable managing it in primary care? This coordination, it's great if you've got a heart failure team that's, you know, hospital based or community based that can link you in with specialists. This is a huge problem, getting people to adhere to medication, and certainly I have huge challenges up here in Northland getting people to continue taking your medication, particularly when the underlying cause of their cardiomyopathy may be alcohol or methamphetamine, and that's again, you know, a huge epidemic. These specific patient cohorts, you know, you need to be a little bit you know, and this includes things like, you know, rural patients or patients that with low health literacy, medication cost and access. Again, use whatever options that we can to get funding, whether it's through WINS or chronic care funding, to help them access their medications. Okay, so again, these are just some of the challenges and inequity where inequity is in no particular order other than alphabetical. These are hugely important, and it's a topic all in itself. But I think it's something that, you know, we as clinicians, nurses, pharmacists, you know, we need to be, you know, developing systems that overcome some of this. Okay, I think I'll finish there if that's okay and take some questions.
Got a couple of questions that have come through. One, can you comment on losartan and gout? Should we be using it in Māori patients with gout?
Yeah, I mean, there is a little bit of evidence that, you know, losartan is a preferable agent in terms of, you know, causing less gout. It's really hard to tease out whether that's related to something specific about losartan or whether it's more got to do with the diuretic dose. But certainly I think if you're thinking of, you know, one sartan versus another pril and the patient's got troublesome gout, I'd certainly, you know, try it. It's one of those, you know, subtle things that may improve tolerability.
Thanks. Another question there. Empagliflozin for type 2 diabetes and AF?
So AF, I mean, there's not a lot of evidence that, you know, it will reduce AF and diabetics, but we know that it reduces every other aspect of heart disease, whether it's, coronary, ischemic or heart failure. So intuitively, it should long-term be beneficial.
Another question there, Raewyn. How soon after swapping from cilazapril to another agent should you follow up the patient?
So I think if you're doing a, if you're doing a swap in a stable patient to an equivalent dose, you probably don't have to. If you're using that opportunity to bump up the dose, I would check their renal function in 2 weeks. And I mean, generally, if you're increasing dose of any of these agents, around that 2-week stage is always a good opportunity to assess some blood pressure, renal function, and clinically if there's any fluid problems.
And I gather that's more important for use of these agents in heart failure than what it would be for ACEs for other conditions?
Oh, absolutely, yeah. I mean, the heart failure patients are a bit more fragile, yeah.
Okay, if a patient is newly given Entresto for heart failure and is already established on other meds, so ACE inhibitor, ARB or diuretic for hypertension, should we expect them to stop their heart failure meds or continue on them?
Okay, so Entresto is, it's a swap, it's not an add-on. So if you're starting your heart failure patients on Entresto, then of course you don't want them on an ACE inhibitor or an ARB. If they're on other antihypertensive agents, such as, amlodipine or, for example, you may not need that for their blood pressure. And often we will sort of cut back on their other antihypertensive agents to allow us to get the Entresto dose up.
Great, thank you. Right, another one there. By how much should we be reducing diuretic doses when starting empagliflozin in your experience? And how close together could we start Entresto with empagliflozin?
Okay, yeah, that's a really good question, because it is unpredictable. I mean, I don't automatically reduce the frusemide when I start somebody on Entresto, but often at that 2-week follow-up, I do. With empagliflozin, I would certainly get somebody stabilised on one drug before you introduce the other. So for example, if I've got somebody stabilised on Entresto, I'd probably wait then with the empagliflozin. The empagliflozin diuresis tends to be a lot quicker. So you may want to sort of assess that person and consider reducing the diuretics, even after the first week or so. Monitoring the patient's weight is incredibly important. Our heart failure patients, are used to sort of watching their daily weight as an indication of fluid loss or fluid gain. And, that's probably the most important time that we should get them monitoring weight.
Lovely. What advantages does bumetanide have over frusemide as a loop diuretic?
Yeah, so bumetanide, there's not a lot of difference. Bumetanide tends to have probably more of a predictable bioavailability. For example, if somebody's got gut congestion or they're not eating well, they've got diarrhea, I find bumetanide is a bit more predictable. Very rarely, people will have sort of, frusemide related rashes where you can swap them over. But the only other benefit, I think, is in those really severe patients that, it's really hard to get dry and they may not absorb their frusemide.
Okay. Sticking with diuretics, should all heart failure patients be on a combination of loop and thiazide diuretic?
No. So it depends on the severity of heart failure, and a lot of patients with severely low ejection fractions don't need much diuretic, and conversely, once some with ejection fraction of 40 need quite a lot. So the right dose of diuretic for that person is the one that keeps them euvolemic. I wouldn't add a thiazide to a loop diuretic until you get to about 200 milligrams of frusemide a day, and then throw the thiazide in and they work collaboratively.
Is there any evidence for using an ACE inhibitor and an ARB in combination? I've seen this being used in community, albeit very rarely, this person states.
Yeah, that's a good question. Certainly a few years ago, there was some early trials thinking along that lines, is that, you know, maybe if we use them both. The problem is that there were too many adverse outcomes in terms of hyperkalemia and renal impairment. So it's really not recommended, whether that's for hypertension or heart failure.
Thank you. Other questions there. You mentioned that Māori people in their 50s are more than 7 times more likely to be hospitalised with heart failure. Any ideas what can be done to address that disparity, Raewyn?
Oh yeah, I wish I knew. I think a lot of it is, you know, right at the coalface is that patients are more likely to accept ill health. They're less likely to access primary care. And I think that's a lot of it, I think, is related to, you know, the comorbidities. Obesity is quite a high one up there, and smoking. So a lot of these patients will be overweight, they get breathless. Heart failure is not on their radar at all. You know, they may think their feet are getting fat, but, you know, so is Uncle Bill's. And, you know, so I think we really need to get that heart failure awareness out there into the community.
I can't see any more questions from attendees at the moment. One thing I was interested in was seeing those international stats showing how few patients achieve the recommended dose of heart failure meds. Why do you think that is?
I think there's a lot of physician apathy. You know, most of the people in trials will get, you know, doses up because they're monitored and up titrated. But in the real world, I think there is, you know, prescriber apathy and also, you know, patient reluctance. You know, patients often, you know, don't like their medication being put up. They feel that, oh, I must be getting worse, or I'm not getting better because the doctor's increasing the medication. And I think that's why right at the start, that sort of awareness that this is a long-term condition, we are going to be adding medications, we are going to be increasing them, and getting that buy-in is the way to go. And that multidisciplinary team, you know, I can't do that with all my patients. A GP certainly doesn't have the time to do that with all his heart failure patients. So I think we need to utilise, you know, community nurses. You know, it would be great if every hospital, you know, rural or otherwise, or, you know, community practice had a heart failure specialist nurse.
Okay. Do you think tolerability plays a role there in terms of blood pressure and renal function, or you know, adverse?
I mean, yeah, certainly it does. So I mean, it will stop, you know, a lot of patients getting up to the maximum dose. The other thing that is interesting is that even in sort of the quite severe heart failure patients that we see here, is that we may sort of get to the maximum dose of whatever agent. And then if we see them 3 months later, their ejection fraction has improved, their blood pressure's improved, and then we can just gradually nudge it up. So what might be the, you know, maximum that you've achieved now may be quite different, you know, 6 months down the line. Okay. So again, reviewing it, you know, is really important.
Right. A few more questions have come through. What do you advise stable heart failure patients regarding fluid and salt intake?
Yeah, so stable heart failure patients. So one thing about the stable heart failure patient is that stable doesn't mean that they're no risk. You know, they're low risk, but even these stable patients will still be on that trajectory of, you know, decompensation. So I think, you know, there is always that opportunity to review their medication. You know, that low salt diet actually is really important. In terms of fluid restriction, you know, maintaining, you know, 1,500 mils of fluid intake a day in a Northland summer is absolutely ridiculous, for example. So my general advice to the relatively stable heart failure patient is drink if you're thirsty, but try not to go, you know, over 2 litres, you know.
Loop diuretics, is it correct that the dose effect is on-off, i.e. if 40 milligrams furosemide is effective, but further diuresis is required, is it more effective to add a further 40 milligram dose later in the day rather than increase the morning dose?
Yeah, I mean, there is some evidence for that, at bigger doses, but if you're talking about 80 milligrams, I'd still get them to take it in the morning. Right. I think if you're getting to the sort of 80 BD, I'd rather give 80 in the morning and 80 at midday rather than all in the morning. That's kind of confusing. So I think in general terms, splitting it does theoretically have some benefits, but it's really inconvenient from the patient's point of view. I mean, I think they're better off to take the dose in the morning, get their peeing over and done with.
Get on with the rest of the day. Yes. Okay, so you've answered the following question there as well. Don't see any more questions coming up just now. Raewyn, we've still got 12 minutes left to the end of the session. Did you want to carry on with one of your case studies? Or
yeah, I can do that. Yeah, people are going to have to answer the question, sorry.
Oh, okay. Well, hang on. We've got one more question here. Adherence can be a problem for patients. Some stop and restart medication suddenly. Are there significant negative outcomes from this, for instance, with blood pressure fluctuations?
I mean, probably not. I mean, the stopping one, of course, is the issue. Usually when people stop their medication, we usually just start them back on, what they were on before. The situation where if they stop and decompensate and end up really sick, we often have to sort of restart again. But
one more question. If the ANI dose is increased and creatinine rises, how much of a rise in serum creatinine would you consider for the dose to go? How much of a rise in serum creatinine would you consider before you go back to a lower dose, I think is what.
Oh, okay. So first of all, and we often see when you start Entresto, and similar sort of things actually happen with empagliflozin as well, is that often there is this sort of slight rise in creatinine, and we're talking, say, for example, from 120 to 140, for example, that kind of order. So that will often happen, and I tend to not change the dose. I'll review the patient and sort of, if they're dry, I'll back off on the furosemide, for example. And then often if you don't do anything, the creatinine will go up and then come back down to normal. Okay. And again, the other thing is, that usual thing, make sure they're not taking anti-inflammatories and things like that. So if the patient's not dry and it's trending up, then I'll just reduce back down to the lower dose. In practical terms, most of the time, if you just recheck it, it comes right. We call it just a little blip. Yeah.
Right. So what do you think? We've got about 10 minutes to go. Mm-hmm. Are you saying for the case studies you've got, you're wanting some contribution from the?
I do, yeah.
Yeah.
I'll put one up and we'll see how we go.
Okay. Okay.
Okay. Right. Can we see that?
Yes, yes.
Okay, all right, so we've got a gentleman, classic story, new to your practice, so you don't know much about him, apart from the fact that he's had a diagnosis of hypertensive heart failure a number of years ago. He's had some peripheral vascular disease with no intervention, and he fronts up with his old prescription, and this is what he's on. Okay, so cilazapril 2.5, metoprolol, and aspirin, and simvastatin. He is NYHA class 2 symptomatic status, so that's basically breathless when walking up hills and stairs, but he can walk on the flat. He's got a bit of leg edema, otherwise he's not a lot to find. He's got an ECG there, which anyone can comment on that at the end. His BNP's up a bit, renal function's normal, elevated GGT, he's not diabetic, and his LDL is 3. We do have an old echo that he's got an ejection fraction of 29% with a dilated LV. So that's all that we've got. So I'll put it to the audience then. What further information do you want and how are you going to manage it?
Right, do we have any takers? Right, why not on a diuretic, someone asks.
Okay, yep, that's a good question. So he wasn't on a diuretic, but he should have been. He certainly should be now because he's got leg edema, he's breathless, and his BNP is up. Okay. He may not have been on a diuretic before because he was stable, and as I said to you earlier on, a lot of people function very well without diuretics. So I think I'd certainly put him on a diuretic now.
Someone else suggests increasing the statin.
Absolutely, yep. So I would put him on, and the basis of that is he's got peripheral vascular disease. We often think about, people that have had coronary disease, putting them on a statin. Remember, peripheral vascular disease is atherosclerotic, so he should be on 80 milligrams of atorvastatin. So what are we going to do with his cilazapril?
So someone's just said increase cilazapril to 5 milligrams.
Oh, okay. Are you going to keep him on cilazapril?
Someone said give him Arnie instead.
Well, yeah, absolutely. He's got reduced ejection fraction. He's got symptomatic heart failure. He's already on a reasonable dose of beta blocker and cilazapril. So yeah, absolutely. Yeah. So use that opportunity.
Someone else that says switch cilazapril and up titrate.
Yep. We're assuming you're switching to Entresto and up titrating. Yep.
So several people have mentioned Entresto or an Arnie. Add an ARB instead of cilazapril.
I mean that is reasonable. It's but he fits the criteria for an Arnie, doesn't he? Are there any other sort of non-medication related things that we want to be thinking about?
Someone's queried HbA1c.
He was non-diabetic.
Okay. And what if we don't know the ejection fraction and can't get or doesn't want an echo?
Okay, well that's right. I mean, ideally he should have an up-to-date echo, but I think if we know that he's had poor ejection fraction in the past and he's got symptomatic heart failure, that's reasonable. Okay. It would be lovely if echoes were accessible.
Someone else has asked about alcohol consumption or raised GGT.
Absolutely, yeah. So he's presumed that he's had hypertensive heart failure, but yeah, exactly the alcohol thing. Yep. Yeah.
So reduce intake. Someone's asking what is his blood pressure?
His blood pressure was about 110/80.
Okay. Someone else suggests diet, weight loss, smoking. Query smoking cessation, salt.
Absolutely, all those things. Yep.
Another comment: it's hard to get an echo if ECG, chest X-ray, and BNP are normal.
Yeah, and that is true. So I would certainly, in this chap, I would use his old echo.
Someone else is asking what his weight or dry weight is.
Yeah, how do you assess someone's dry weight? I'll put it back to the audience. Any takers?
Not yet. I'm hoping for some quick typers. Here we go. Morning weight. Yeah,
morning weight. Yeah. So I think that's so. Certainly, people should be, weighing themselves at the same time each morning. Pee, pooed, and weigh, so that at least it's consistent for them. But the dry weight is where the patient is got no leg edema. They've got clear lungs. Their JVP's normal. And conversely, they're not thirsty. So they're not dry and they're not wet. Yeah.
So someone else has said wait when there's no leg edema.
Yeah. Yeah, I mean, on the alcohol thing, I think it's actually really important because not only is alcohol a significant risk factor for cardiomyopathy. And if we're talking, about our, 50-year-old Maori, for example. So I think asking questions about alcohol and other drugs, particularly methamphetamine, is actually really important, because if you don't ask, you don't get the answers. And it's a thing that's complete cessation is the way to go. The other thing is that if this chap that we were talking about truly does have hypertensive heart disease, we still want him to abstain from alcohol, because if your heart is weak from whatever reason and you add another insult like alcohol, it's not going to be tolerated. So, regardless of the original cause, it is important to, cut the alcohol back.
So someone else has suggested checking family history, drug abuse.
Yeah.
Another question there. What about overuse of salbutamol driving heart rate?
I'm not aware of. Well, there's two things. One is that a lot of people have asthma, have been diagnosed as asthma, but in fact have heart failure. So I think there is actually a lot of people that are overusing inhalers and turn out to have a cardiomyopathy. If somebody is tachycardic for whatever reason, we want to be slowing them down anyway. One of the issues with tachycardia, whether it's an atrial tachycardia or atrial fibrillation, can lead to cardiac dysfunction itself, and that's part of the way that the beta blockers work.
And someone else has just mentioned about his compliance with prescribed medicines. Just quickly, we're bang on 8 o'clock now, so just quickly sneak this last question in. How do you justify statins with normal cholesterol profile despite PVD or CVD, and what will be the dose?
Oh, okay. So if they've got, well, first of all, what's a normal cholesterol? Okay, because most of the lab things will be saying what's normal, not what's ideal. Okay. So the way of thinking about it is, if you've developed atherosclerotic disease with your cholesterol, it's too high for you. And the lower we can get it, the better. The lower we can get it now with, standard, non-specialist drugs is atorvastatin or rosuvastatin. Yep.
Great. Right, well, we're bang on 8 o'clock. So if you're happy with that, Raewyn, we'll wrap it up.
No, it's good discussion.
Yes, thank you so much for that. It was good to get some questions coming through from the viewers there. And also great to see we've moved quite some way on from diagnosis of dropsy, use of Southey's tubes, and bloodletting with leeches. So, yeah. So thank you everyone for joining us. This concludes our session for the evening. Thank you so much, Dr. Fisher. It's been a really interesting and informative webinar. So thank you everyone for joining, and ka kite anō.
Okay, thank you. Have a good evening.
Thank you.